Welcome back, everybody. Let's get started. It's my pleasure to introduce the next speaker, and we're going to continue on this theme about talking about knowledge generation and integration. And it's wonderful us to have with us today Mark Bellis. Mark is the director of the Center for Public Health at the Liverpool John Moores University. They are a WHO collaborating center for violence prevention. He also directs the Northwest Public Health Observatory. That's the lead UK observatory for public health intelligence on alcohol, drugs, and violence. And Mark leads on alcohol issues for the UK Faculty of Public Health and sits on the advisory board for injury and violence prevention to the Director General of WHO. One thing that Mark has been working on that's of particular interest to us and is one of his many wonderful projects is the evidence projects with the WHO, which really gives him a unique perspective on what we know about what works about violence prevention globally. So, Mark, please come on up, and thank you very much for taking the trip over here to be with us.
Thanks very much, Jim, and thank you very much to all the organisers for inviting me. It's been a really fascinating day already. I've been asked to cover all sorts of things. The evidence base that we look at, something about framing that in terms of a life course or introducing that, and before the panel and the presentations afterwards, some of the issues around high, low, and middle income countries. The debate about evidence has been really very interesting. I think, and clearly the definition of it is vital. There is something else, there's insight as well, and the insights I sort of carry around is that people who have nothing act like they have nothing to lose, and I'm going to try and bring that out there. And the other is that with even on a sort of common understanding, those who are introduced into violent environments as young children learn those as survival and as strategic options much earlier and in a much different way. So I'm going to try and bring that out through some of the information I present. I'm going to focus on one or two areas as we go through, not necessarily because they're more important, but because they introduce subjects, I think, which bring some contrasts into how evidence can be looked at. I think most people are familiar with these, but just to say, interpersonal violence, again, I won't go through these, but that's largely what we're going to be talking about. But in the session after this, there will also be self-directed violence, and some of those elements might come through in one or two of the issues I bring up here, but not collective violence, so the larger groups of individuals or those where there's wars or political violence, although there's clearly crossovers between each of these. So the basic requirements, and just taking a step back from often quite expensive programs, and again, a discussion at the moment about what can you pull from the high-income country evidence base. But lots of these things, I think it's just first to remember, rely on an effective criminal justice system being in place, functional, accessible care systems being in place, a functioning school system for so many other things we talk about. Otherwise, there's no delivery mechanism. A research-based evidence, that's been touched on a lot here. Where can we, when we know most things aren't assessed, can we say that we are pulling from the right evidence base in order to make assessments about what might work in low and middle income countries? Is the monitoring and surveillance to actually continue those projects to see whether they work or not? Political support for prevention. And again, part of this, or at least in the beginning, is based on evidence, but there is an element of a jump, an insight, which is necessary in order to make the next step. And the problem with evidence often is it's very evolutionary. So it takes one thing and tries to develop from that. And if you're not in the right place in the first place, you've got to think about how the things which have no assessment at the moment are brought in. And equity is another issue I'll come on to. Propensity for violence. Plenty of information perhaps that hasn't been talked about so much, but it is a unifying field because these are often constants across different communities. Genetics, epigenetics, so non-DNA coded changes in genetic expression, fetal exposure to things like alcohol. And then, of course, adaptation. I'm going to come on to adverse childhood experiences and those early life experiences and the evidence around what changes those. And what's been described as developing a her trigger, which means that people move to violence much more quickly, and as a result of that, disengage in a whole variety of important environments, such as school, and end up being more more disengaged from the general community. And then the triggers, they can be ecological or environmental. The sort of what are you looking at thing where people interpret cues that what most of us would see as neutral as being aggressive. This is from the World Health Organization. I've just cut it down a bit. But again, the framework, again, some of you would be familiar with for looking at these things. So being an individual framework. So some of the things that people are trying to press upon, being male, there's not much we can do about that. Substance use, low intelligence, attention problems, poor school, and then relationship. And I won't go through all these in detail because of time, but things like parental conflict in a household, single parents, having a teenage mother, I'm going to come back to, the friends that people have. And each of these are pressure points which we know are risks, but we don't necessarily have interventions which match up or change these. Community, presence of guns, drugs, gangs, urban environments, high crime areas. And then the societal level things, particularly things like poverty, which are again consistently related to these problems, and I think mean that often we are playing in a relatively narrow margin of change when it's very difficult to find environments which are, say, very poor and have very low levels of violence on a consistent basis. So things like media violence as well, economic inequality, and cultural norms that support violence. This is the data from the whole of England for accident and emergency, and I just wanted to just show a life course and just some differences. So these are males, and this shows you accident and emergency presentations for violence for the country, and you can see the peak is around 18, and it gives you just an idea of how much a problem, particularly in those early or mid-teen years, violence is. But these are the most affluent people in our country. That's the same peak for the most deprived individuals. So the 20% most deprived. These are females, and these are deprived girls and women. And just as an example, and I could have used other countries, but the data, we do have complete data for the UK. So by the age of 13, a female in a deprived community is experiencing higher levels of violence than the actual peak, which is at 20 years for those in the richest 20%. So the lifetime experience is vastly different. And even if we focus in the low age groups, the experience of violence, which is even presented at A&E, which is only a small proportion in the first place, is much, much higher in the deprived environments than it is in the more affluent ones. And exactly the same is true when we get to the older age groups, when we're looking at elder abuse, largely as older people as victims. The problem is, this is from the London riots, some people may be familiar with. By the time people have got to this age, that boy there is probably 8 years old, he's already part of a gang, and much of the problems which he has are already set in. He doesn't think he necessarily belongs to the community culture, but to a particular gang environment. The things that people have mentioned already, which from some of the reviews you can do, but we primarily look at primary prevention, but there's behaviour change counselling, so not a huge amount of effective evidence around that. Family therapy, people have mentioned multisystemic therapy, and there's evidence around that as well, with follow-up evidence as well. So for these people who are already in problems, we've got programs for offenders, so cognitive behavioural therapy, and that's been talked about in some detail in a previous presentation. Gang programs, again, they've been talked about, including Boston Ceasefire, and how the evidence varies across that. Youth inclusion programs, which is another good example because it shows that some of these things can have iatrogenic effects. So we have problems around some youth inclusion programs making things worse. And mentoring programs, which are often quite popular, particularly in some other countries, but aren't necessarily backed up by the best evidence, although there is a little. So again, people may be familiar with the adverse childhood experiences. So we're just taking a step back now and looking at some of the influences which hit people before they get into that situation where they need that second level of interventions. People, I expect, will be familiar with some of this, but experiences before the age of 18. So we're looking at things like abuse in the family, neglect. So this is children in their early life who've experienced families with these problems. Household dysfunction. So issues like mothers being treated violently, an incarcerated member of the family, or substance abuse, and a parental separation or something along those lines. Now, what I want to show you here is two things. Just the figures are slightly different, but they're still relatively consistent. These are figures from the UK on an ACE study, and the USA, slightly different tools, slightly different outcomes, but more or less the same pattern. And one of the important things, I think, is first of all just how many things are being influenced by these early life interventions. And I'm going to come back to that as an important issue. So low mental well-being is coming out. It's not just later on in life violence, which I'll show. Things like severe obesity, which was one of the main drivers behind the ACE studies. Whether someone's a current smoker or not. Alcohol abuse, illicit drug use. Whether people perpetrate violence later on in life. So these are as adults now. But we're talking about the experiences they had when they were a child and what the relationship is between them having 4 or more problems like that, and later on the risks of these issues happening. A couple of things we can add in the UK one, whether they were born early in life, so whether they had a teenage mother, whether they've had unintended pregnancies early in life as well, and whether their first, from the US one, first pregnancy was unintended. So what I want to just get people into thinking about here is a cycle, really, whereby the exposure early on in life is leading to a variety of things which are causing or also linked, at least linked, let's say, to unintended pregnancies and births in teenage mothers later on in life. And that's part of the cycle I think people are talking about. So what can we do in terms of primary prevention with people at that stage, effectively to avoid those ACEs? Well, there's things like dealing with relationships with parents and child maltreatment, so we can do safe and stable relationship interventions. Low academic achievement. So here we're talking about developing life and social skills, and we'll talk about what those are in a second. And I know people later on this afternoon are going to be talking in more detail on them. How do we address the cultural tolerance of violence and high community violence? So can we challenge the cultural and societal norms that support violence within communities? Another type of intervention group. Access to weapons, so reducing access to lethal weapons, and access to alcohol, which is, for me as well, a critical issue, and whether we can reduce that and the harmful use of alcohol as well. Now, I know people will be talking in detail, so all I've done here is summarize these, and I'm certainly not going to read them all out, but things that fall into each of these categories are like the family nurse-family partnerships, and people have referred to the importance not only of knowing that they work, but what the cost benefits look like, and that's critical information when people can decide between these different programs. Developing life skills, so here, developing an emotional skills, often again at the early life stages, often targeted at the poorer communities like the Seattle Social Development Program, and again, I'm sure there'll be more examples of that sort of thing later. Challenging social and cultural norms, largely done around bullying interventions or bullying programs. The obvious program being one of the most famous, taking a whole school approach with peer-led, teacher-led interventions or elements within the program and an evidence base behind that. And reducing access to lethal means. And I know a very particular topic at the moment here, but a variety of pieces of information, particularly around how legislation has changed in different countries. And the one I've just picked out here is around the Austrian gun reform laws and how they changed some of the outcomes, particularly around suicides and firearm-related suicide and firearm-related homicides subsequent to the changes in the law. Yes. Yeah. Yeah, Australia did do some changes as well. There's about 4 countries which there's examples of in something I'll come on to. The reason I put this up is because before I said that the importance of early life prevention is often not just issues which deal with violence in later life. And it relates very much to how we address cost effectiveness. So this is a UK piece of work. It's an economic analysis. So what we're looking at here is school-based social and emotional learning programs, rather generic, and prevention of conduct problems in childhood. So the cost of the actual intervention is £132. And the question is, what's the cost effectiveness level of that? Now, in this particular case, it's modeled that cost is borne by the school or the education. So if you look at the payoff to education in terms of educational outcomes, it takes 5 years in terms of what their payoff is. But if we look at the total payoff of that intervention, which delivers on a variety of things across criminal justice, voluntary sector costs, health and social costs, it actually pays off within a year. So there's a question for violence prevention and violence interventions about where we make our, if you like, our combined efforts, particularly when we're arguing about the cost effectiveness of interventions. And often it's worth, or people focus on a particular area, violence as a specific outcome. But the issue is also what other benefits are being delivered by exactly the same programs, and where can the collaborations be thought of and made in terms of making the argument for an economic investment. And I think this sort of points to where it's worth working with people with similar outcomes. I thought I'd focus on alcohol for a slightly different reason. I just want to show the different sorts of interventions which can be brought to bear on the same problem, and then you have to make a decision between them and how they can have unforeseen circumstances. The data for alcohol, or again, the biochemistry behind it, there's quite a lot of work on it. Warning signs are mixed because of variety of other parts of the brain which are affected by alcohol, lower self-control, poor information processing. There's a very old phrase which says in vino veritas, which basically means when people drink, the truth about them comes out, which is probably not the most complimentary way of looking at it, but there is an element of that as well. And individuals' actual beliefs that alcohol causes problems can have an issue as well, or at least it can act as an excuse. And then there's another thing around alcohol, which is poorly managed drinking environments, which is often what a lot of countries focus on. So I'll talk in a second about the concept of can we allow people to get drunk safely as a public health message. So these are those. So we can improve environments. And a lot of this is about violence reduction, or the arguments for why it's funded. We can do licensing, award schemes, staff training. In the US, probably better than most places, there's been stuff done properly on server training so that people drunk aren't served as much, but even then it's sometimes patchy. Train door supervisors, or bouncers as we call them. How do we police the environment outside? Lighting, closed circuit television, we are very keen on in the UK. Late night transport is a critical issue because normally what we're assessing is whether people are being involved in violence in the environment in which they're drinking. And that's quite important because there's a question about whether we're actually dispersing violence or whether we're actually treating the problem. And I want to come on to that in a second. So we can do provision of security. And targeting policing is the big one. A lot of talk is talked about. We put police where people drink a lot. But one of the things I want to point out, first of all, this is where I'm from. So this is Merseyside or Liverpool. There's two sets of pictures on this. One is the dots. That's where violence happens. And they're all focused, you just have to take my word for it, around the bars in the city centre. And the second one is where people live. And the reality is that we normally, from criminal justice perspectives, focus on where the violence is happening. And that points us to a criminal justice answer, because there's not much a nurse or a midwife or someone can do once we're talking about policing a particular environment. But the people who are involved in those fights come from very specific areas. They're far more likely to come from the poorer areas and the most deprived in communities when they're involved in those fights in the first place. So there's two elements here. One is about, there is something about how environments are managed, and there is an evidence base around what you can do to do that. But actually, the underlying issues are very different. The underlying issues are something to do with the poverty in the environments in which those people are growing up in, as well as the environments they're exposed to during alcohol. So we've got proximal and distal effects. The problem with focusing on the nightlife environment is the answer is, as long as you get them out the nightlife environment and the statistics for the city centres look okay, then we're doing our job. No one really cares about this. This is what happens when you get home. This is what happens when someone falls asleep smoking. This is what happens when someone goes home because they're drunk, and some of the issues that we talked about in the previous talk happen. And there's also issues about child and other sorts of abuse in the house as well. So by actually just pushing the problem out, we're not necessarily curing it, even though we may in one area be tackling violence. A good example of this is, again, what was talked about in terms of the app, is non-consensual sex. This is a study, again, from the UK. This is over 1,000 university students, 18 to 24. By the time they've got to that age, nearly a third of them have experienced alcohol-related non-consensual oral, vaginal, or anal sex since the age of 14. They are more likely to have drunk, and they're more likely to have drunk fast over shorter periods. That's nothing to do with blame. That's just an epidemiological description of what happened. 2/3 of participants disclose their experiences. Now, most of these won't happen in the city centres, although they may have started out there. They'll happen when people get back home or in private parties. But only 9 out of 184 told the police. The others all just tell friends. So if you're pushing things into certain areas, you're not necessarily going to see this in routine monitoring. So you have a range of options. You can do early life support systems, like I talked about at the beginning, preschool enrichment, life skills training to tackle alcohol. That has an impact. You can limit the times of sales. I haven't talked about that, but that's another one. You can look at the density of premises, so you can look at access. That's another one. Or you can change the accessibility other ways through price. Most of these, there's certain evidence bases at different levels around their impact on violence. Some of them have multiple impacts because the early ones impact not just on alcohol-related violence, not just even on violence. And others may have unforeseen consequences, particularly if you're environmentally managing and displacing alcohol-related violence. This is a summary of the work Jim mentioned we did with the WHO. And the black dots, these are prevention strategies. I'm not going to go through them again, but they're the ones I showed at the earlier slide. The black dots are where we have, I guess, what people here would have called high-level, well-supported evidence with randomized control trials, and they're pretty thin on the ground. The open dots are the ones, they're going across the top here. It's child maltreatment, intimate partner violence, sexual violence, youth violence, elder abuse, and suicide. But the one I'd like to point to as well, which I think is really important, is there's absolutely nothing in the column for elder abuse. Nothing at all there. And I'm going to come back to that in a second. So some areas are almost entirely empty in terms of what we know about interventions that work on primary prevention of these issues. What we do, and it's supported by WHO with support from CDC as well, is we run a website. It looks at primary prevention studies. And in that, you can go on. It's very similar, different structure to ones that have been presented here today. You can pick different types of topics, and you can search for what's happening in terms of published studies which look at actually addressing the reduction of violence and whether they've succeeded or not as a primary violence issue. What you look at, what you find is this. There's still relatively few that make it through the inclusion criteria, and this is preventviolence.info if people want to go to it. The vast majority are on youth violence, child abuse, self-directed violence then, sexual abuse, intimate partner violence. One study globally on elder abuse. And the other thing which I think people have already talked about today, and again part of this next session, is this is in Kenya, one of the biggest slums in the world. And what relevance do these studies have to a place like that? What relevance do they have in general? That's when I was there looking at alcohol production there. And what relevance do the studies on alcohol-related violence have to a system like that? And if we look at those 237 studies and how they're distributed in terms of the geographical evidence, that's what they look like. The Americas have, and primarily the USA, have the vast majority of those studies. There are only 5 that meet the criteria currently in Africa. They're almost all South Africa, and they're almost all related to HIV as well. There are 1 or 2 more coming through at the moment, and we also run a database based on emerging results, which actually covers studies which are already in progress but haven't reported yet. So there are some other information coming through, but fairly thin across the world, considering that the countries with the smallest stars are often some of the ones with the biggest levels of violence in them. So my final slide, going back to the beginning, the problem is that there is a cycle, a life cycle, from birth going round, even if people make it through secondary school in some places, whereby there are then things like unplanned pregnancies. I'd argue people who aren't prepared to be parents or supported or have the resources in the right way. The option is, can we get to a position where there's positive parenting, employment, and further education, which are going to make critical differences, but aren't necessarily just seen as violence issues? There's a range of protective factors, I've tried to cover most of them, that can be put around that circle to ensure that it goes that way and not the red way, and just creates a loop which continues to produce people with problems. But around that, we have a range of other issues. So identifying and supporting victims, I haven't spoken about, reducing alcohol and drug use, which again are issues which will impinge on all these. And around that is a whole different system, which we have to understand our position in, I'd argue, around effective social care systems, reducing social inequality, and effective criminal justice systems, which in themselves have an impact, but also are critical to make sure that those things in the middle can be delivered, at least at the moment, in the ways that we understand about delivering them. If people want more information, there's a variety of things on our website and on WHO website as well, and these are the reports which I've drawn from to put the information together for this talk. Thank you very much.